tonight we're really lucky to have Matt talk about an article that he published in 22 with Michael Pinsky and John Marini. And the article is titled, "Are We Ready to Think Differently About Setting PEEP?" So Matt, thank you so much. And with that, I will let you take it over.
Okay, so yeah, thanks for giving me a chance to talk about this. I think most people here in this discussion, though, don't need this article. So it was written in response to observations during COVID-19 and managing patients, and the way came across some patients with ventilator settings that didn't make a lot of sense. So I started thinking about why that might be and how we got into this situation with some, not all of our COVID-19 patients. And it prompted us to write this article when we were sort of talking about these observations that we'd made. Now, I think the only reason for discussing this with an audience like you guys is because the article prompted this so within 3 weeks of our article being published, this follow-up paper was published, and after some discussions with the Crit Care editors, we discovered there was a break in the workflow, so we weren't given a chance to respond, but we've already written our response. The paper by our colleagues from Rome was highly critical of what we published, and I think comparing these two papers is probably what makes this an interesting topic for a group of experienced intensivists like ourselves. So what did we say in this paper? And then I'll go on to what Grieco and his colleagues said. So we were really just focusing on, we think we've probably got a bit lazy about PEEP over the years. It's very clear from 2000 how we should ventilate patients that meet ARDS criteria, but it's less clear on what we should be doing with PEEP, and we have all these studies. And despite all these studies, we still don't have a clear idea of what to do with PEEP. And the impetus to write this paper was this is the chest x-ray of one of the first COVID patients I came across. I got involved with their care about 14 hours after they'd been in ICU. This is their chest x-ray just before they were intubated on a high flow of 60%, oxygen sats 90 to 95. And actually they weren't really in any major distress. But there was concern because they're on 60% high flow that they might get worse, and they got intubated. Within 14 hours, when I got involved with their care, the patient was on a PEEP of 16, paralyzed and proned, and on an FI of about 0.8 on 6 mils per kg. And I was going through the x-rays, and that scenario made no sense to me at all based on what was going on with the chest x-ray. And the pulmonary mechanics didn't look really too bad. They weren't normal, but they didn't look like what I'd expect them to be in a patient that's paralyzed and prone. Normally the x-rays a lot whiter, the lungs are a lot stiffer. So what I did for that particular patient was just try turning down the PEEP. And when we turned down the PEEP, suddenly we didn't need 80% oxygen anymore. We didn't need noradrenaline anymore. And we actually got the patient down to an FiO2 of 0.4, deproned them and turned off the paralysis. And by the end of that day, they were awake on a spontaneous mode, quite comfortable, and were starting to think about extubating the patient to high flow. So when I reflected on that case, I sort of thought, well, how did we get here? And I think part of the reason we got into that situation was because of the way we applied PEEP. Now, my ICU out of hours most of the ventilator settings are determined by our respiratory therapists, because our juniors, they don't do a lot of ICU in their training, and we don't have ICU senior residents covering at night. Our respiratory therapists, it's probably the same in most hospitals. There's quite a range of knowledge and skills within respiratory, within that group in our hospital. And some like to follow the PEEP FiO2 table. And I've got this slide on to show that really that we can't be critical of that, because if you look at all the studies done in the last 20 years in patients with ARDS, it's very clear we have not yet found a PEEP strategy that's superior to the original PEEP FiO2 tables used in the ARDSNet study. Which, in the alveoli study, they asked the question, well, if we couple the ARDSNet lower tidal volume strategy to low PEEP versus high PEEP tables, can we make a difference? And they showed probably not. But one of the things when I actually put, this is a slide from a talk I gave a couple of months ago. When I put this slide together, one of the other things that struck me that never struck me before was all these studies were designed with the hypothesis that the intervention arm needs a higher PEEP than the control arm for all patients. And I think that might actually be a clue to why we have not yet discovered what our best PEEP strategy is, because when we're studying it, we're always locked into this question, and the studies are all designed to try and get a higher PEEP in the intervention arm compared to the control arm for all patients. And that might not be true based on the way ARDS can present in the ICU. But given all those strategies, and the alveoli we're all familiar with is the simplest one, high PEEP versus low PEEP table. As you get down to the more recent ones, EpiVent 2, this was the Daniel Telmar's esophageal pressure monitoring, FARLAP, the stepwise recruitment, de-recruitment maneuvers. These interventions require a bit of training, bit of experience, require somebody to spend a lot more time at the bedside. So if there's no difference in mortality, why spend hours at the bedside when you could just follow a PEEP table? And I think that's a reasonable strategy. Nobody in ICU is sitting around thinking, I've got lots of time on my hands. But when we look at the PEEP FiO2 table, what is it really asking us to do? Well, we're using an FiO2 to keep our oxygenation measure, whether it's PaO2 or SpO2, within a specified range. And we're kind of chasing that with the PEEP. So as we go up on FiO2 to keep our oxygenation in a set range, we increase the PEEP following that. But what we proposed in this paper, what we wanted to highlight and get people thinking about is when you do that, you're making an assumption. Or you're making an assumption about why the patient in front of you has hypoxemia. And the assumption you're making is that the dominant mechanism is alveolar collapse, and that generally that's associated with a reduction in compliance. But you're making the assumption that as you go up on PEEP, then you're increasing recruitment of functional lung units, and that will ultimately improve oxygenation. It will also improve compliance. And we think of ARDS kind of as this, sometimes I think, a homogeneous group, and forget that it's actually quite a heterogeneous group. And in many ways, when we think about PEEP in ARDS, this is no different to the first paper that was published by Ashbauer back in 1967. If you look, I've just circled the important words in their abstract: hypoxemia, loss of compliance, positive end expiratory pressure, most helpful in combating atelectasis. And I don't think we think about ARDS in any other way since this paper. But we posed the question in our comment piece of, well, what if this isn't the case? What if you've got hypoxemia and it's not all due to alveolar collapse? What will the PEEP FiO2 table cause you to do in that setting? Now, the first question we were supposed to ask, well, is this a reasonable, valid thing to postulate? And I think it is. And this is a paper that came out after COVID-19, but it's looking at the lung safe and the ESCIM trials group ARDS data. And they just broke the non-COVID ARDS patients, so before COVID, up based on compliance. They split them into compliance phenotypes, lowest compliance versus probably relatively preserved compliance in some of these patients. You can see it within their data set. See, only 75%, well, not only, about 3/4 of the patients had reduced compliance and probably fit what we think of with that standard ARDS picture. But around 25% didn't necessarily meet that picture. And we have to ask ourselves, well, if you've got preserved compliance or relatively preserved compliance compared to impaired compliance, should those patients be getting the same ventilator and PEEP strategy? Now, it shouldn't surprise us that we have different groups of pulmonary mechanics within our ARDS group, because the ARDS definition, nowhere does it actually include measures of compliance. It only includes really measures of oxygenation and chest imaging and a few other criteria. So it's not a surprise that actually we have heterogeneity in terms of pulmonary mechanics within this group of patients. So what might happen to these patients if we use the same PEEP strategy as we do in these patients? Well, there's this nice study. It's a bit old now. It's 2005, but it's an Italian study. And what Grasso and his group did was they took 19 patients with ARDS and gave them the alveoli PEEP table. So they gave them a few hours on the low PEEP table and then transitioned to them to the higher PEEP table. And they asked, do all patients respond the same? Do they all experience lung recruitment, first of all? And they realized that actually only about half of their small cohort experienced lung recruitment on the higher PEEP. The other half didn't. And it gets quite interesting when you look at, well, what did that mean to the patients? Well, perhaps no surprise to us, the non-recruiters experienced, if anything, a slight reduction in the PF ratio at the higher PEEP. It's probably some things going on, some over distension perhaps, and reduction in cardiac output, whereas the recruiters got exactly what you want and exactly what we hope to see when we're increasing PEEP and when we're following the FiO2 PEEP table. Subsequent to that, and I'm sure most of you are familiar with this was from Caroline Calfee in San Francisco. They went back and looked at the ARDS data and the alveolar study data and asked a question, are there different types of patients within this ARDS group? Now, using latent class analysis, which is a tool from biology, it's been used since the late 1800s, actually. The first paper I could find using latent class analysis was a biology paper published in the 1890s. They were trying to figure out, they were looking at Naples crabs and were trying to figure out if there was 2 species there or 1 species. And so it's a way of looking at a group of patients and how you sort of look at the average for a bunch of variables of your whole group. And then you look and see, well, do some patients or do some species or animals cluster above the mean or below the mean? And what they found was that in ARDS, if you look at inflammatory measures, you have this group that cluster below the mean for some of the inflammatory markers like the cytokines, above the mean for things like bicarbonate, so less acidotic. Then you have this other group that are hyperinflammatory that cluster in terms of cytokines well above the mean, and then below the mean for things like bicarbonate platelets. So these are more acidotic, more evidence of cytokines circulating around. So hyperinflammatory doesn't mean there's no elevation in cytokines. It just means they're less elevated compared to the mean of the group. The hyperinflammatory is more elevated compared to the mean of the group. But it got really interesting when they asked the question, well, how did these respond to PEEP? And the hyperinflammatory group, perhaps no surprise, their mortality was better with the higher PEEP. And, you know, hyperinflammatory, if we think of what the lungs might look like in those patients, this probably isn't a surprise. Then if we think of what the lungs might look like in a hypoinflammatory patient, then it's probably no surprise that actually they did better with the lower PEEPs than with the higher PEEPs. So you've got these two groups that respond completely differently to PEEP within the alveoli study. And what I find interesting is most of the patients were in the hypoinflammatory group, and they've applied this analysis to several other things, like Danny McCauley's statin studies in ARDS. And again, the surprising finding that actually the majority of the patients fell into the hypoinflammatory group rather than the hyperinflammatory group. I found that quite interesting. Now, we don't know how these align with compliance phenotypes, and I suppose it's, to us who are interested in ventilation, it's still a surprise that we're still doing ARDS studies and not necessarily always collecting a lot of compliance data. Pulmonary mechanics data. But it begs the question then, does this make sense anymore? Does the PEEP FiO2 table make sense if we have these groups of patients that respond differently when exposed to these PEEP tables? And it also begs the question, what if you have a group like Grasso's non-recruiters, right, where as you're going up into the higher PEEPs, the PF ratio is starting to get worse? What does that mean? Well, if your PF ratio is getting worse and then you're going up on the FiO2, then if you're following the PEEP table, then you'll go up on PEEP, and then you'll go up on the FiO2, and then you'll go up on PEEP, and you can get sort of stuck in this cycle. And I wonder if that was what was happening with some of the COVID patients, like that first experience I described. Now, I think one of the reasons COVID has maybe brought this to the forefront is simply because my observation with early COVID actually fits with this really nice paper that was published over 2 years ago now, where they focused on the fact that, you know, COVID-19, it binds to the angiotensin 2 receptor. Now, that does exist in the lung epithelium, but it also is in large quantities in the endothelium, the pulmonary vessels. So as well as getting areas of pneumonia and pulmonary inflammation, you also get disturbance to the endothelium of the vessels around that, around the inflamed alveolus. And one of the consequences of this is you lose the normal vascular tone. You get impairment of the normal vasoconstriction. So you have an area of pneumonia, and at the same time, you've lost the normal hypoxic vasoconstriction because of the endotheliitis, as well as maybe some blood flow issues, microthrombi, and things like that. But these two papers I thought were really important, and perhaps not, I didn't see them discussed as much as I expected to see them discussed, because they did like CT perfusion scans of the COVID-19 lungs. And what they found in both of these is Bridge Patel from London and Gattinoni, of course, we all know. On the CT scans, the areas of collapse and consolidation actually had hyperperfusion, which you wouldn't expect to see, but it's because of the endotheliitis and the loss of the hypoxic vasoconstriction. But what that means as a result is you get this VQ mismatch in COVID, certainly in early COVID pneumonia, that creates a hypoxemia that's out of proportion to the actual level of lung collapse and inflammation. And I think that's kind of where we got into trouble with the PEEP FiO2 tables in our COVID patients. Imagine you've got a chest x-ray like this, but the patient's very hypoxemic and you start cranking up the PEEP following the PEEP FiO2 table, you can easily see that you're going to start to cause over distension and be ventilating on too high a PEEP. And these are just a couple of the compliance things. This is patients before COVID, and this is taken from that earlier slide I showed. This is Gattinoni's thing that sort of kicked all this off. You do see there is a slight shift in the mean for the COVID-19. It's subtle, but it's probably, I think with COVID-19, we saw patients meeting ARDS criteria without the severe impairment in compliance that we usually see in patients that meet ARDS criteria. Now, all of you are experienced intensivists, and you know that actually you've all seen patients that meet ARDS criteria, but they don't have pulmonary mechanics disturbed in the same way that we conventionally think of. So we're all used to seeing these patients, but I think what was different about COVID-19 was we had a run of these patients compared to our normal day-to-day practice. I just put this slide out to remind me that, of course, the trouble with the PEEP FiO2 table, I think, is when you're going up and you're not recruiting lung, you can still be rewarded with an improvement in the PF ratio and the oxygenation, partly because of Henry's law, which you all know about, but also partly because if you cause a slight reduction in perfusion of the alveolus, or you slow the red blood cell transit time as it goes around the alveolus, it will pick up a little bit more oxygen because it's exposed to the air fluid interface for a little bit longer. So you get a little bit rewarded early until your cardiac output starts to become significantly impaired, and then your oxygen delivery is impaired, then your oxygenation starts to fall away again. And of course, as you're doing that, you're causing over distension and all these negative consequences. So I wonder about the PEEP table, and we started to think, well, we can't just publish something like this and say, can't use the PEEP FiO2 table and not give people an alternative. So we concluded that, look, we should probably think a little bit differently, maybe not just focus on oxygenation. Oxygenation is an important outcome, but it probably shouldn't be how we set our PEEP. Let's use something that's simple, available to most people at the bedside now, especially in terms of the dynamic compliance. If you're adjusting PEEP, look at what's happening to the pulmonary mechanics. And if they're getting better, then your new PEEP is better, whether you're going up or down. If it's unchanged, then you're going to have to look at the chest x-ray, look at the patient, make a clinical judgment as to what direction you want to move in. If it's impaired, then your new PEEP is probably worse for that patient. And we argued that it's relatively easy to do at the bedside now, because this is some old data from, a long time ago, 30, 40 years ago. Following compliance using dynamic compliance, which is calculated from the flow, volume, and pressure. This is proportion assist ventilation, doing a very cleverly timed breath hold that's less than 300 milliseconds at the end of a spontaneous breath. So what these slides are showing is, look, they're correlating very well with our normal compliance measures, and can be relied on even in a spontaneously breathing patient. We also referenced this paper, which was from Bellini in Italy, again saying a similar thing. It's difficult to see on the screen, but if we just zoom in, also suggesting titrating towards compliance and maybe making some other measures, looking at EIT or cardiac ultrasound, if you find yourself in very high PEEP ranges, to make sure you're not over distending or impairing cardiac output. But of course, there are limitations to compliance, and I think amongst the group of us, we should discuss that. And we expected letters related to limitations of compliance. We didn't expect this, and this was from our colleagues in Rome. And what they basically said is compliance is unreliable, you can't use it, but didn't provide an alternative, which was a bit unusual. this paper was very rapidly published within 3 weeks of our paper being published. So they got through peer review 3 times as fast as our original paper got through peer review. But what they argued was, based on their COVID-19 patients, so they had 30 COVID-19 patients. They published this work in 2020, created a really nice physiology data set of COVID-19 patients. They argued that in their COVID-19 patients, whether they were PEEP of 5 and went to a PEEP of 15, they could stratify them into 3 groups: those that had a increased compliance, those that had unchanged compliance, and those that had diminished compliance. And they argued you can't use compliance because, look, all these patients, there's no statistically significant difference in the recruited volume across these 3 groups. And it's an interesting argument to make. But I think this is also something we should discuss amongst ourselves, because the way they grouped these patients was like, increased compliance, the ones that when they went from a PEEP of 5 to a PEEP of 15, they experienced their compliance increased by more than 5, diminished, decreased by more than 5, and unchanged was didn't move by, it was within 5 of the compliance at PEEP of 5. Now, they said because of this, you can't use compliance, it's too unreliable. But I think they've made an assumption. Now, this is the alveolar de-recruitment maneuver. So you go from PEEP of 5, take the pulmonary mechanics, go to a PEEP of 15, patients on 6 mils per kg tidal volume ventilation. They then stay at PEEP of 15 for 30 minutes, take the compliance, take the pulmonary physiology measures again, and then you drop the PEEP by 10. And during that breath where it drops, you measure the difference between the set tidal volume and the expired measured tidal volume. And that gives you a sense, I think it's quite a clever, simple bedside measure, gives you a sense of what lung was recruited at that higher PEEP, or the volume of lung recruited at that higher PEEP. But I think to use this to argue that you can't look at compliance as a guide when you're setting PEEP means you have to accept this assumption that when you move a patient from a PEEP of 5 to a PEEP of 15, their compliance has changed in a linear fashion. And I don't think that's the case. That's not my experience at the bedside. And that's not the experience in the literature. This is a nice study where they did decremental PEEP titrations in patients with ARDS. And they found, like you can see from this, the optimal compliance was somewhere between, I guess, 6 and 12. And that fits with my experience at the bedside. I use compliance to set PEEP, and often my patients end up on a PEEP somewhere, usually actually not between 6 and 12, usually probably between 8 and 14, I would say. So I actually think this is what the assumption you have to make their argument based on the data they presented. But this is where I modeled what I think probably happens. And I used that respiratory paper data to say, look, if the optimal compliance is somewhere between 9 and 12, what will the compliance curve look like if you were titrating in steps from a PEEP of 5 to 15? Rather than just jumping from a PEEP to 5 or 15. And I think it's important. I don't think we can reject compliance as a measure. And there are, again, I think we should discuss some of the limitations of compliance measures. But when we're setting PEEP, if we're using compliance as a target, we're not saying compliance is perfect, but we're saying, for our patients with ARDS, don't we want to set PEEP where we've optimized compliance? Because Marcelo Amato showed us quite nicely. Oh, sorry, I didn't put his reference on this slide. No, if you've optimized compliance for a given tidal volume, you've also optimized driving pressure. And don't we want optimized driving pressure with our patients with ARDS? I think we probably do. It seems to be associated, though we haven't, I guess, truly demonstrated a causal relationship, but it's certainly associated. The lower the driving pressure, the better the outcome for our ARDS patients. And again, we can discuss all the potential confounding and stuff in this data, but physiologically, it kind of makes sense. So I think it's a trade-off, but I don't think that the data from what our colleagues in Rome presented is enough to say you can't use compliance to set driving pressure. Now, that's my last slide. I think that ended up being a bit longer than I planned.
Wow, that was great. Thank you very much, Matt. Sure, the audience has comments, thoughts. Someone like to kick this off? Andreas?
Yeah. Congratulations. I mean, you hit the mark. Graham keep asking me, showing our data on repetitive inflation and deflation in an ARDS model, and the assumption that that we're working. If you look at the PV loop, the assumption that we're working in the linear part at all time. If you increase your PEEP from 5 to 15, and it's a linear relationship, is really nicely shown if you perform repetitive PV loops in different. That was an experimental study. That it is not linear as well, and I could almost match with the outcome of our ARDS model with repetitive PV PV loop measurements. I can replicate your assumption of where you find the ideal, compliance. Unfortunately, I don't have it at hand. I would just bring up the slide. It would replicate exactly what you're saying. So I think as a response to your comment in critical care, we should go and start really publishing this data, because it fits 100% sure in there. I think your assumptions are right.
It would be interesting. You should get that published.
Well, while we're discussing, I'm going quickly and try to bring it up if I can find it that quickly.
Take your time. Jeff, you look like you wanted to say something.
Yes. Thanks, Matt. Jeff Shaw here from Christchurch. That was great presentation. I'm actually asking a question which is somewhat ignorant, but I just want clarification. I've got the paper written from the gentleman in Rome, and I just really want to ask a question about exactly what they are doing when they talk about recruitment to inflation ratio. Is that simply just a ratio of two different compliances at two levels of people? What exactly is it?
Yeah, it's essentially that. So the original paper was some Chen and Laurent Brochard. So it's the ratio of compliances. And when I first looked at the IR work, I sort of thought it was interesting, but through this and looking more closely and being forced to look more closely at it for a rebuttal, I realized that it's making the same assumption, that is the change in compliance is linear between 5 and 15, and I don't think that's a safe assumption.
You're 100% correct. We've been involved in measuring compliance across a whole number of patients as well, or measuring what our method was to measure the elastance with a linear regression model, and we've got very similar pictures. It's certainly non-linear. What I thought was interesting with this recruitment to inflation ratio is I just broke it down to the units, and I look at the PEEP. Basically it's the compliance at the high level of PEEP and divided by the compliance at the low level of PEEP. When you put the numbers in, you cross multiply them, they come out as a ratio of two different lung volumes. But there is a problem, and the deal is in the detail. When they do this, they use a volume control setting.
Mm.
If you use a volume control setting, then your mathematics breaks down because the delta P doesn't cancel out on both sides of the equation. You'd have to use a pressure control setting to make sure that the comparison of the two volumes is correct. And if you use a volume control setting, I was reading somewhere that most people give them, say, 500 ml tidal volume, put them on sort of volume control ventilation. If you have non-linear increase or a decrease in compliance or increase in elastance, then you're going to get some pretty wacky results. So what I'm trying to say is that if you ventilate someone at the same driving pressure at 2 levels of PEEP, and then you do the comparison of the elastances, you should end up with mathematically a difference in volumes. But if you do the same thing by using a change in tidal volume, because you've got non-linear changes in compliance, you will end up with something which doesn't really make sense, and it'll be all over the show. So if you follow my reasoning, so I think that the method, haven't thought through the methodology right, because I certainly, when I do my recruitment maneuvers, I always use a pressure control mode. I never use a volume control.
Yep.
Because of the non-linearity of compliance, and the fact that compliance very, very much goes off as you start to wind the PEEP up. And particularly whilst you are, say, recruiting a patient, sometimes you do need to wind the PEEP up a lot, and suddenly things begin to open up, and it's pretty unpredictable. So I wonder if there's something, what I have to say, that is responsible for the almost the random nature of this data the recruitment to inflation ratio, or the recruited volume. In other words, the degree of recruitment seems to be pretty much independent of the compliance of the patients. And I think that part of the problem, and the reason we've got some of the results they have, is simply because they are using a volume strategy to recruit patients and not a pressure strategy, which tends to pretty much exaggerate non-linearity in compliance changes as you start to overstretch the patient.
Jeff, sorry to interrupt. Jeff, I can't understand what you're trying to say. At the end of an inspiration or inspiratory hold, you'll have a pressure which is equal to the same volume, the same compliance. So whether you use a volume or pressure, it'd be the same. What is the difference you're saying? If you're using if you use the same volume to get the same pressure, you'll get the same pressure, the same compliance. It doesn't matter whether it's delivered as a volume or pressure. I'm not quite sure what. I'm sure there's a point. I just don't understand it. That's all.
Okay. Well, I might have this completely wrong, but that's why I really want to, because when I was reading around this, I don't measure recruitment to inflation ratios of my patients, so I'm trying to understand exactly what is done. But I imagine that you have the patient at 5 centimetres of PEEP, for example, and you measure the compliance of the patient. And then you wind them up to 15 centimetres of PEEP, and you measure the compliance of the patient. That is correct, I presume. And then your recruitment to inflation ratio is the high compliance at the high level of PEEP divided by the compliance at the low level of PEEP. You've got a number, a unitless number. Now, my point is this: is that if you write down what the units of compliance, which is change in volume over change in pressure, or the driving pressure in this case, and then you divide one by the other, you find that the driving pressure cancels out, and you end up with 2 different volumes, which I think is quite nice. But the driving pressure is different if you have a non-compliant lungs, and it's greatly exaggerated. And so those 2 delta P's don't cancel each other out, so they therefore do not represent true differences in volume. So you end up with a totally meaningless statistic. Does that make sense? I'll give you an example. If I have a patient who's on, say, a driving pressure of, say, 10, and they've got 5 centimetres of PEEP on board, and let's say, for argument's sake, whatever it is, the math says that their compliance is 50. And then I wind them up to 15 of PEEP, and I have a driving pressure of 10, and I've got a much lower tidal volume. And so let's say my compliance has fallen from 50 to 25, okay? But if I left them if I put them on a 500 ml tidal volume in both cases, what happens is at 15 centimetres of PEEP, the driving pressure is much, much higher than the driving pressure was at the lower level of PEEP. And the result of that is that you no longer get the relationship of your driving pressure and your tidal volumes by a constant compliance over that breath, within that breath. The compliance is actually reducing as the breath is increasing within that breath itself. So you end up with a bit of a random number generator. And you'll end up with different answers. I'd love to see the data. They haven't done it, but if you looked at to measure compliance, because it's non-linear and it does greatly change within a breath, it's very, very important that we make sure that the methodology doesn't, that what we're measuring, when we measure compliance, we're basically making an assumption that in one breath it's fairly linear.
Yeah, you're just
But
saying that we need to pay attention to the details. We know that different ventilators measure also in different ways. Some ventilators provide a dynamic compliance using a least squares methodology. They have, accuracy and precision. And I think we need to study the tools that we have. And it would be nice to have a uniform approach to measurement to compare the data in a more effective way. But right now, I think it's even important to get people to understand what they're doing with the tools they have. Andres, did you find your data?
Just give me a minute, and I think I found it. Yeah.
Can I just check, Jeff? I think I'm understanding what you're saying. You're essentially saying if you've got a fixed tidal volume at two different peaks, and you're measuring compliance with a fixed tidal volume, some at the higher peak in particular, you're probably at risk of causing over distension in a way which is going to distort your compliance measurement. Whereas if you're on a driving pressure, you won't see that same change. Is that correct?
Yeah, that's exactly. So you can imagine that you could have a tidal, let's say at the low peak, you both got tidal volumes of 500 and a driving pressure of 10. If you go to 15 a peak, to get the tidal volume 500, you might need a driving pressure of 20. All right. Now, if I made the driving pressure of 10 and measured the compliance, I would get a different number than I would if I got a driving pressure of 20 and measured the compliance.
Andres, did you get it?
Yes, I got it. I share it, hopefully.
Okay. There we go.
Okay, can you see that?
Mm-hmm.
Okay. Just to explain to you what we did. So we had a smoke inhalation injury model in sheep. And that creates a huge response. You get very sick lungs, and these animals normally even don't survive beyond 8 hours or 10 hours. So it's a very severe injury to the lung, smoke inhalation. And what we did was each of these sheep were exposed to repetitive PV loops. And the way we did the PV loops was, the first one was done from 5 PEEP to 10. Then from 5, then deflated again down to 5. The next inflation happened to 15, deflated down to 5, then to 20, deflated down to 5, and then 25 as the max that we applied. So we got basically 5 PV loops in a row, and they were quite slowly performed. So it's a quasi-static compliance measurement that we could do. And the sheep were sort of ventilated because there was during these PV loops, there was some tidal volume change happening. So they survived this maneuver. And when you measured the compliance on the inspiratory limb of each of these PV loops, they have a huge hysteresis, each of the loops. We measured the compliance at each of these loops, between 5, then again when we go to 10, when we go to 15. So each loop had a compliance given in the so-called linear part of the inflation limb of the loop. And as you can see that we could see in this animal model that if you look at the inflation part greater than 20, you start losing again compliance. And so what you just demonstrated, your PEEP relationship to compliance is not a linear relationship. It is actually a curve as it occurs. So that's the top curve that you can observe. Disregard the open triangles. That's on the deflation limit measured. Obviously, you get a different compliance measured if you measure it at the deflation. We always look at what's happening during the inflation. It would be actually as well interesting to see what the compliance is during the deflation. And on the lower graph, it's the left and the right lung separated, measured by EIT, because in this model, because the animals were positioned, as far as I remember, in left lateral position, you got more injury in one lung compared to the other because the smoke distributed in the non-dependent lung created more injury there. But you can see this behavior of the compliance in relationship to PEEP quite clearly. So your assumptions are just shown with this paper that this is correct.
Yeah. That's nice work, Andreas.
Yes, can I tell you, we were arguing the case in 2008, the first time, and they said it's rubbish, it can't be true. Okay.
Yeah. Thank you. Ross, do you have any comments about the...
Just, no, I do, but one of the things I'm struggling with my head with is that the compliance change over inflation is non-linear. I absolutely agree with that. And it's made up of really three parts. It's the non-linear compliance of the alveolar itself. Each individual alveolar will have a compliance curve, which is non-linear. And then there's the effect of that each alveolar is different, and there's 300 million of them, all with a slightly different compliance, which the combination of that gives you the shape of the curve. And then there's the third thing, which is, I guess, what we're dealing with ARDS is the recruitment part of it. And they're separate entities, we combine them into one. And I wonder if we can tease out what is the change that's occurring. Is it because we're re-recruiting? Is it because we're moving alveoli into a better part of their own compliance curve? And I think I've always, when we put those compliance curves up, I think they mean different things to different people. Sometimes when you look at a compliance curve, you're thinking about a single stretch of a single alveolus being overstretched and understretched. And other times you're thinking about the combination of a population. And I think the answer to some of our problems is that we're dealing with a population of alveoli, all of which are different, which gives us the shape of the curve, and that will change depending on the population. This spread of population of alveoli. So,
can I just reshare it's exactly what you said. If I reshare this graph here, so you see the behavior, regional behavior. So you're right. We have 300 million alveoli in theory, but if we're looking just at the left and the right lung, so the closed and the open symbols are representing the left or the right lung, and the right lung, the left lung. I need to correct me. So the open circle here is the right lung, and the open square is the left lung. And you can see the behavior of the left and the right lung in relation to compliance is very different. And we know that one lung is sicker than the other lung.
Yeah.
And with the EIT, we have the opportunity, I don't have the data in front of me, but we have as well an estimate of the lung volume that occurs, or the recruitment volume that occurs. So you need to put the volume recruited per compliance or the compliance per volume, or standardize it against volume. That would be probably the right answer to look at the question: how much alveolar space has been recruited, and only can be done with means of lung volume estimates, may be EIT, which is the easiest, can be done with some gas, inert gas washout again, but more tricky. But I'm absolutely in agreement with you. We need to measure the lung volume at the same time as well.
Can I ask a question, Matthew? It was a very nice talk, but practically, do you think, do you adjust PEEP with increasing PEEP, or do you think it's better to recruit than decrease PEEP to find the best compliance?
I don't think we know yet. I don't think we know whether setting PEEP decrementally or incrementally is a better strategy. We could argue that the South American study, the ART study, showed that increased the ART study, what they did was that quite extraordinary lung recruitment maneuver on pressure control, and then dropped the PEEP down to about 23, and then did decremental PEEP, seeking a PEEP that had the optimal compliance. Now you could argue, and also that the colleagues from Rome in their paper made this argument that then that argues against using compliance, because that was the one PEEP study that showed increased mortality. But I actually argue that they didn't set PEEP for optimal compliance, because what they did was they found the PEEP at which compliance was optimal, and then for some reason did a recruitment maneuver and then set PEEP 2 centimeters of water above that level, which I suppose what they're trying to do was keep the lung open. But actually, in my experience, the classic, I mean, I had an unusual patient the other day, but a PEEP of 6 was too much for them. And when I dropped to a PEEP of 4, which it's unusual for me to have a PEEP below 5, but on a PEEP of 4, the patient's pulmonary mechanics were much, much better, and were able to turn down the oxygen. So I don't think we know. And what we didn't cover, and this is why I was surprised to get that letter, because we purposely didn't cover recruitment maneuvers coupled with a PEEP strategy. Because again, I don't know the answer. I don't know what's the best lung recruitment maneuver to do. I always thought that stepwise recruitment was actually a nice way of recruiting the lungs, but following the FARLAP and the ART study, I still think we need to recruit our lungs, but we need to do it sensibly, because what surprised me in the ART data was that when they had a lung recruitment protocol, people followed that protocol to the point that patients had cardiac arrests. And that to me is surprising. It's that you could be at the bedside doing a recruitment maneuver and keep following the protocol until the patient has a cardiac arrest. And I don't understand myself how that could happen at the bedside. So I've always been a lot more cautious about telling people you should do a recruitment maneuver, even though I think they're important. What we don't, the other things we don't know the answer to is, and it's something I'm interested in looking at some point, is that generally, if I think the PEEP is too low for a patient, I found myself sometimes titrating PEEP without doing a recruitment maneuver. And in that setting, I'm titrating PEEP upwards, seeking the optimal compliance for those patients. And what I don't know is how long I need to wait. How long do I wait if I've adjusted the PEEP to be certain that then the compliance, or what we're really measuring, and I think we probably need to introduce this term into our language, the average compliance. How long do we wait till the average compliance is stabilized? And And again, I don't know the answer to that question. I generally wait 1 to 2 minutes, but I don't actually know whether that's safe. There's only one study I've been able to find by Gattinoni yet again. What is very clear is the new compliances reach faster when you're decreasing PEEP than when you're increasing PEEP.
Moving blood.
Again, I wonder whether we should be using term average compliance to remind us of what we're truly measuring when we measure compliance on the ventilator.
So Matt,
As Andreas's data did.
Can I just? It's from infant pulmonary function tests. In infant lung function tests, you normalize compliance per lung volume, FRC.
Okay.
Because we know that we have, particularly in this population, a huge range of what is normal FRC, and because they're breathing as well very closely to the so-called closing volume, you may have a very rapid drop in FRC or a rapid increase because they collapse and open the lungs. So it's quite a standard that you normalize compliance per measured lung volume. I'm talking here about spontaneous breathing infants, pulmonary function test in the outpatient clinic. But what you do is actually you put them in a plethysmograph, measure the lung volume, and do compliance measurement and normalize this for lung volume measured. And we're not doing this in ICU. We assume that they're all the same.
It's true.
So Matt, I'm Mike Gentile. We haven't met, but I applaud you because you've asked the question. You didn't pick a fight, but you've asked the question and you've got a response. I wouldn't consider a mark on your back, but at least you raised the question. So, PEEP has been around since 1967 and we're still debating it now, right? So either we're very thorough researchers or we're very slow to learn, right? And so I did a similar project to Andreas with an animal lung model of ARDS, and I stood by my poster at the ATS, and Warren Sanborn, who some of you know, walked up to me and said, "Good job, young man. You have reproduced Peter Suter's work from 1976."
Yeah.
And it was, compliance, it was dead space, it was cardiac output to deliver DO2, which is what we're all about. And so I was embarrassed because I did not read Peter Suter's work, but I did a good job of reproducing it and match the curves just like your curves too. And so, but we're all trying to do DO2 and then lead to outcomes, but then we don't have cardiac output, so there has to be some surrogate, right? And just by you asking the question, you've opened certainly the topic. And I've sat through many and traveled with John Marini many times and heard his, incremental and decremental PEEP talks. And we still argue about the optimal PEEP, right? Best PEEP, optimal PEEP. And, we still argue about that. In 2004, I wrote our editorial saying the optimal PEEP, the search for the Holy Grail continues, and it's still continuing, right? So I think it's good because we don't know, what are we going to do? And you said something very telling. You went to a PEEP of 4, right? And if I take a survey of all of you, how do you measure or how do you do your PEEP? You do it in 2s, right? A very brave person does a PEEP of 9, right? Because then there'll be a write-up by the nurses or respiratory therapists say, patient found on PEEP of 9, it must be a problem, right? So because we do 8, 10, 12, well, what about 11? Is 11 good or not? So I think that it continues. And I was also part of the ARDSNet. And the ARDSNet was we had to figure out a way to get people a goal, right? An oxygenation goal. So that's where the tables came up without looking at mechanics, without looking, the EIT didn't exist at the time, without doing anything like dead space, because people didn't want to do dead space. esophageal balloons, as you mentioned, and certainly Danny Taylor's done a great job with it, but you have to be an expert in it, right? And so at 4 o'clock in the morning, if you're working with a group that doesn't know how to do it or troubleshoot it, it's useless, right? So I applaud your looking at compliance and doing it, and at least having that sort of give us a basis, because it is readily available. And Steve, of course, pointed out something very good. Ventilators are different. Some do it. You know, if you look at all the, if you look at the ventilator you have or use the most, go to the manual and try and figure out exactly how it measures compliance. Some are inspiration, some are expiration, et cetera, et cetera. So there's a little bit of variance too. But I applaud you, because if anything, then this group can come up with a thought-provoking way to say, what do we do now?
Yeah.
All right. And I will get down off my soapbox, and also I will email you offline with a couple other thoughts.
Awesome.
But I applaud you for doing that. And you're right. It's always interesting to see the response.
Yeah. Response was not what I expected. I expected some different responses.
Oh, I expected responses too when I saw your paper, and I was like, oh, here we go. And that's when the fight starts. Because if you go to a bar at night, at 11 o'clock at night, and everybody's had a couple of drinks, and you just throw this out there, then people are going to argue. They're very passionate.
Michael,
it's also
you said you
frustrating
were
for us. Yeah.
What's
It's
that?
also frustrating for us that teach, you know, we have trainees, because we should have the answers, right? We have a lot of very definitive things in medicine, but when it comes to this, we're kind of a little wishy-washy, right?
Mm.
And so we want to make sure they go out and do good things, and that's the challenge.
Yeah.
So if I can say something, Matt, I thought that was a good presentation. I think, like Ross said, it was a lot of stuff there that tested us. But and you and I have had this discussion before. Not all ventilators, and I'm just going to be very general, I say this, have the optimal tools or the optimal measurements that we need to use. For example, certain machines have tools that can look lung recruitment and setting PEEP, but even the tools themselves can be different. Like Jeff said, if you want to do like a pressure control, a pressure, breath way is very different. So you want to control, obviously, in a quasi-static approach, pressure ramping of inflation, then pressure on the decrease as well. Not because normally the flow control only works in one part of the curve. So if you're just looking at PV loops, you're going to be very, very limited. Only the inspiratory component there. But the thing would be, in your situation where you described some patients were recruiting and some weren't, then having a tool to assess the patient first and say, listen, we can't go any further, this guy's a non-recruiter. And, if they are recruiters, okay, then we go to plan B. What do we do next? Because you might see some other signals, for example, like lung closing pressure. For example, where optimal people should be. I have a strong bias here, but I just think sometimes not all ventilators give us the tools to use in the ICU.
I think what also you're highlighting is, I didn't want to come across too negative about the alveolar de-recruitment maneuver, because as a tool for determining whether the patient has recruitable lung, I can see that it has value, right? And there's probably slightly safer ways of doing it than volume control, as Jeff mentioned. But determining whether someone has recruitable lung is different to determining the optimal PEEP for that patient, right? All it tells you is that 5 was not the right PEEP, right? It doesn't tell you what the right PEEP is. And if they experience in that maneuver reduced compliance at 15, but they've recruited lung, I think what it tells you is their optimal PEEP is between 5 and 15, right? It doesn't actually, it can't be used to reject determining the PEEP, because you're not going to, after doing that maneuver, you're not going to say, okay, they've recruited lung, their compliance is worse at 15, but I'm going to leave them on a PEEP of 15, right? That's not how you're going to set PEEP. So I think that the way the response was written it was either just because I wanted to say something negative about the paper without giving it as alternative, or it's because the primary author didn't understand the limitations of the maneuver, and that I suspect it might be the second one. I think what is interesting in their data, and this is probably what spurred them on, because I suspect their original paper was to challenge the H&L phenotype discussions that were happening in early COVID, is all but 3 of their 30 patients did have some lung recruitment. Okay, so they all needed, other than 3 of the patients, needed a PEEP higher than 5. But what was also very clear was for at least those cluster of patients that experienced lower compliance at a PEEP of 15, a PEEP of 15 would be too high, which is exactly what I saw with that first COVID case I saw when they were on a PEEP of 16. It was too high for that patient. And we do harm if our PEEP's too high. I also have been, the more I think about the topic, I don't want to come across as too negative of the PEEP FiO2 tables, in that oxygenation is an important goal when we're thinking about PEEP. But the limitation is, if we're not recruiting lung as we go up on PEEP, we start to run into problems. So it doesn't work for all patients. And I suspect, and while Michael was making his comments, I started thinking, actually, perhaps part of the reason we're getting into these PEEP wars, for want of a better description, so we haven't defined what is our goal of PEEP, right? It can't, it's not a single goal, actually. And that's what I was thinking of with that last trade-offs thing. It's I want a PEEP that optimizes lung protective ventilation and optimizes oxygen delivery. And if I'm using compliance as a measure, I'm optimizing potentially driving pressure, and I'm setting the PEEP that allows me to give a the optimal lung protective ventilation. And if I'm not over distending lung and things, then I'm probably not impairing the cardiac output, and I'm optimizing oxygen delivery, just like Suta showed a long time ago. And I actually, like you, I only was reminded of it. So John Marini sent the paper to me this week. Interestingly, when I was adding it to my library manager, I realized it was already in my library. I just didn't have the PDF of it. But these older papers, we tend to sometimes forget about them. They get lost in our daily thoughts. And I like I don't know if Ross is still with us. I think, but I like Ross gives a good talk about the history of tidal volumes in ARDS, and I've learned a lot from that. It seems like we've kind of gone full circle over 40 years or so.
You know, interestingly, you asked the objectives of PEEP, and from a device maker's standpoint, we need PEEP so that our sensors are energized, so that we have liftoff pressure that we don't actually have to have time delays for. And in many ways, in a closed system, it's the same thing. We're trying to open things up. You know, we're trying to down the pipe. We're trying to get things so that our measurements and our applications are well fitted. But I think all of this goes back to something that we've been talking about for a while, which is having the right measurements to apply to mechanical ventilations, so that we can apply this tube we stick down people and barbarically force power through with some precision. And I think that that's the goal here. And I'm sure we'll have many more discussions in ventilation matters and of course in the literature over these sorts of PEEP wars. And you've given me a good idea for a commercial on ventilation matters. We'll have PEEP wars as a commercial. And so that's great. Thanks everyone.
Power, right?
Thank you, Matt, that was a great talk. Thanks again.
Yeah, thank you, man.
Right.
Thanks, everyone.